Good afternoon. Thank you so much for joining us here today. I hope everybody's had a chance to get something to eat. And if you didn't sign in on the way in, if you could sign in on the way out, that would be useful, just so we get a sense of who is here. My name is Tina Krager. I'm Managing Director for the University of Michigan Injury Center, and we're really pleased to have you here today as part of this event. Just some information about the center in case you're not familiar with us. We're a CDC-funded, University of Michigan-supported research center, and we're focused on injury prevention. We do training and educational opportunities like this one, and we have courses in injury, internships, and fellowships. And we've recently worked with the School of Public Health to offer a certificate of injury, and that's an opportunity for master's level students. We fund research with an annual pilot study competition, and we support practitioners and policymakers by providing information to help them with their injury prevention. We have a couple of events coming up that I wanted to let you know about. On December 1st, we're hosting an opioid overdose summit. At this point, the in-person attendance is fully subscribed, but we do have a webcast option, and that's a professionally produced webcast, so it's a great experience if you need to attend that online. If you'd like to register for that, just go to our website, and there's a link there. Looking further out, on February 3rd, we're going to host Mary Koss for a distinguished faculty seminar. And she's a nationally known expert on sexual violence and has some expertise in the area of campus sexual assault, which is a very timely topic. So watch for information about that. And then our next lunchtime seminar will be in February, and that'll be Maria Music speaking on the topic of child maltreatment. So information about all of these events are on our website, which is injurycenter.umich.edu. So today we're pleased to welcome Dr. Michelle Macy. Dr. Macy is an assistant professor in Pediatric Emergency Medicine here at the University of Michigan. She's done considerable work in the area of child seat safety, and you'll often see her cited in the news media on this topic. Today she's going to share information about her recent pilot study funded by the University of Michigan Injury Center on patterns of usage using geographical information systems. So please help me welcome Michelle. Thank you. And I'm really pleased to see a lot of familiar faces in the audience and some faces that are new to me. I am completely open to having you guys pause me at any point you have questions during the talk. And if you want to just hear me ramble for 45 minutes and then save questions for the end, we can take that approach too. I don't have any financial relationships to disclose, but I do have funding from the NICHD for a Career Development Award around child passenger safety, and this work is funded by the Injury Center Pilot Program. I'm going to touch on things that are going to be, I think, variably familiar to different people in the audience. So the issue of child passenger safety, the improvements that we've seen in the last few decades and opportunities for improvement. And then go into child safety seat checks and GIS very briefly, and then go through the results that we have for the Injury Center pilot study that we have conducted, look at local patterns of child safety seat check participation in the Safe Kids Greater Grand Rapids and Safe Kids Huron Valley areas, and a glimpse at some misuse issues. For those of you who know me, you probably know how I got started in child passenger safety research, and I'm just going to spend a quick minute for those of you who might not be familiar. 6 years ago, I was facing the birth of my third child and facing two other kids who were still in restraint systems and had a sedan that was too small to fit 3 car seats. So being that I was about to start on faculty, my husband, who's an engineer, and I went out and bought a new car. But that kind of planted a seed for me about the challenges that families go through when they're trying to properly restrain their children. Then fast forward 2 months, and there was an NPR story on, as I was kind of bleary-eyed waking up in the morning, about the 3 states that were holding out on passing booster seat legislation. And one of the senators from one of the Dakotas said, you know, it's just a parent's right, and we shouldn't legislate that. And as a pediatric emergency physician, that didn't sit well with me. So when I came back to work, I started talking with the folks that I work with in the Pediatric Health Services Research Group, the CHEER unit, and they're like, this is it. This is where you're going to have a public health impact and be able to kind of marry pediatrics and pediatric emergency medicine with an important topic.
So this is where we get into stuff that's going to be largely familiar to people. Unintentional injury is the leading cause of death for children in the United States and kind of up there with infection in terms of worldwide injury deaths. And motor vehicle occupants for the 1 to 19-year-old population as a whole still remains a leading cause of death. And I know that for older populations, the opiate abuse situation has taken a lead to motor vehicle traffic, and also for some populations, gun violence has taken a lead to that. But for the population that I'm particularly interested in, the young pre-drivers, this remains a leading cause of preventable injury and death. And as we look at non-fatal motor vehicle occupant injuries across the first 15 years of life, we see an alarming increase as we go from those precious babies that everybody wants to take care of when they leave the hospital and get everything right, to the tweens who are starting to exercise their independence and have some pretty strong opinions about where they are in the car and how they're sitting. And so this pattern of increasing injury risk across childhood was interesting to me. If we take a big picture step back and look at trends in injury death throughout the country for the last 30 years, we've made a huge amount of progress. And we being engineering and public health, and it's a big multidisciplinary effort to make these changes. But you can see that since the last 5 years, things have kind of leveled off, and kids in the younger than 4 age range end up still being at the top of that list in the blue and black dots. And then we've still got 4 to 12-year-olds hovering around 10 deaths per million children per year in that age group. So Sweden and other countries have decided that there should be 0 deaths related to traffic injury, and the United States has started to take a look at these policies, and Michigan is also making this a focus. And I think that if we look at traffic injury deaths as a whole, the pediatric population is probably the place that we could get there first. And so I'm interested in trying to work to get us closer to 0 deaths for the child population in particular. And if through that we can increase awareness for parents and other adults and teens, then we've got some positive spillover effects. As I was working on developing my career development award, one of the topics that came up were concerns around disparities in restraint use. And so this has become one of my areas of focus. We know that on a national level, there's lower restraint use among racial and minority ethnic groups from residents in rural areas, and then also populations with low education and low socioeconomic status. And I've been able to do some work that has received a little bit of media attention on that front using national data sets in the publication in the American Journal of Preventive Medicine, and then also using our emergency department populations at University of Michigan at Hurley Medical Center to look at that locally. And we're finding that the disparities persist even after we're adjusting for economic and education level. And so understanding what the bigger context is in terms of restraint use behavior is important. And then the CDC looked at analyses around motor vehicle occupant deaths and found that Black and Hispanic children are killed in crashes at higher rates than population averages would suggest they should be. And part of that ties back to lack of restraint use in those groups. And getting down into my population of interest, kids who are recommended to be using child restraints, rear-facing car seats, forward-facing car seats, booster seats, until they get to a point where they're old enough to sit in an adult seatbelt and have it fit properly. And that's not expected to happen until some point closer to 10, 11, 12 years old. We know that car seats are complicated, and anybody that's ever had to take kids around babysitting or as a parent try to install these things, it isn't straightforward. And that leads us to this problem that 3 out of 4 car seats are incorrectly installed. And child safety seat misuse comes in a range of flavors. It can be a minor couple degree angle difference from what would be optimal to a car seat that's placed into a rear seat of a vehicle and not strapped in at all. There are also issues around selection of the correct restraint for a child's age and size, and that's been a particular focus for me. So I'm going to talk a little bit about child safety seat checkup programs. And this ties in with Safe Kids Worldwide that was founded in 1988 to prevent childhood injuries. There are 450 Safe Kids coalitions throughout the United States, and we have 13 Safe Kids coalitions throughout Michigan. And each individual coalition uses local data and resources to address important injury topics in their area through a variety of different mechanisms. The Buckle Up program specifically was started in 1997 after General Motors and Safe Kids collaborated through a settlement that resulted in some issues related to fires in trucks. And through that program, to date, there are more than 125,000 child safety seat technicians who've been trained, and we've got 36,000 currently certified in the United States. And we're looking at about 900 currently certified in the state of Michigan. The Buckle Up program components include inspection stations where you go and have either an appointment or a fixed location like a fire department or a police station or a community center where parents can go and get their car seat looked at and help with the installation. The technicians are trained to look for problems with the seat, defects, damage to the seat, recalls, and then they also assess the fit of the child in the car seat and the fit of the car seat in the vehicle. It gives an opportunity for hands-on practice for caregivers, and free and low-cost child safety seats can be distributed through these programs. The program goals as published by Safe Kids are to educate caregivers about child passenger safety, to increase correct restraint use, and for seats to be distributed to underserved, low-income, culturally diverse, and special needs populations to close the gap in child safety seat use. I've only been able to find one prior publication on the Buckle Up program entity, and that was a survey that was published in 2000, and 98% of the technicians who were surveyed said they distributed seats to low-income and underserved ethnically diverse populations. But we really don't know who is using these services and who's participating in these programs. And that was one of the things that I'm curious about and led to this pilot work. And the organizations don't routinely collect information about the program participants, but what they do gather on everybody is an address that the family provides. We presume that by and large these are home addresses for families. And so this looked to me like an opportunity to take address information and use geographic information systems approaches to try to get a next step understanding about who's using these services historically. So now I'm going to briefly touch on GIS. And people in the School of Public Health have probably heard this, and it's an important early example of looking to where an event is occurring and where a disease outbreak is happening and putting that on a map and relating that information with where wells were in London and where the sources of that water were contributing to cholera deaths. They were fabled to be able to shut off that water supply and then kind of resolve the cholera problem, courtesy of work done by John Snow. As computers and software programs have become more sophisticated, there are a growing number of applications for GIS, and it provides this opportunity to layer things together to get a picture of complex data to understand a problem. And I don't know if people looked at the New York Times on Sunday. You've got a nice example of a geographic distribution of the uninsured in our country, and it happens to kind of nicely parallel this 1990 map of the outliers of poverty. And the CDC has been, I think, one of the places where public health people are going to be most familiar with seeing some of the GIS work that's been published previously. So now getting to my injury center pilot work. It had 3 aims. First, to map the child safety seat checkup program participation in 2 areas that were willing to provide data for us to be conducting these analyses. And those were the Safe Kids Coalitions at Greater Grand Rapids and Huron Valley. Then I wanted to compare the participation rates by census block group characteristics to give us a little window into who might be the people using these programs. And then also see if we've got any variation in child safety seat misuse across different census block group characteristics. I had a hypothesis that was a little bit counter to what the stated goals of the program for Buckle Up was. And I just kind of, based on the culture of people I know in Ann Arbor, perceived it to be something that affluent, well-educated families do with their first child, and they dutifully go in the prenatal window of the last trimester and get a safety seat installed. And these folks might be otherwise viewed as pretty overprotective parents. So I wasn't necessarily expecting to see results that would show that these programs are reaching the populations that we know to be at risk for low safety seat use or high misuse in terms of low education levels in minority populations. As far as the data sources that we have available, we had the child passenger safety seat checklist forms. These are standard forms that are filled out for Safe Kid car seat inspection program participants. And it's a visual object recognition form that, you know, anybody who took the ACT remembers bubbling through, or I don't, you guys probably took it on the computer now, right? No, okay. But back in the day where you had to bubble things in, then these forms all get scanned in and submitted to Safe Kids in a way that we were able to receive data in an Excel document. We had car seat inspections from January 2011 to June 2013, and we have information about the vehicle, the child, including height and weight and age, the safety seat they were using on arrival, any problems that were identified with that seat, and then the safety seat that was in use on departure, in addition to the address information that I already mentioned. And to try to understand the areas where these families are coming from, we relied on the 2010 US Census and the American Community Survey. The census is something that is gathered every 10 years, and the American Community Survey is little samples of data that are collected about how many cars and toasters you have in your household. And they provide information about different units of geographic area. So a census tract is probably something people have heard mentioned. Census tracts have about 1,500 to 8,000 residents. The census block group is the smallest geographic unit that the census will release data about, and we've got 600 to 3,000 residents. And if you're in a high density area, you're going to have a very small geographic area that's covered. If you're out in the Upper Peninsula, you might need big swaths of land before you can gather up 600 people. For these data, we have several units of analysis potentially available to us. We've got information about the child in the seat on an individual level. Then those children and their seats could, if we've got sibling pairs, be coming in a single vehicle that's grouped together. And then you can have a mom and a dad and a grandma all coming from the same household. For the bulk of the results that I'm going to be presenting here, we're going to look at the seat level and then aggregating things up at the household level. To get to a household, what we did was sorted all the addresses and found places where the addresses matched and assumed that if you listed the same address, you guys lived together. And for places where they indicated an apartment number or a condo, we grouped people up with the matched apartment numbers and condos, even though they map to the same point in GIS software. The outcomes of interest were child safety seat check participation rates, and with that we counted the number of participating households and divided by the number of households with children in a census block group, assuming that most kids who are receiving these services are living in a household. There are going to be some grandparents who have kids with them, and we're not entirely precisely able to get down to that level, but we thought that was more kind of a better estimate of the population participation rate than going with all the households in that area. We created a composite variable for child safety seat misuse and identified any selection error, meaning a child was in one type of restraint when they arrived and they left in a different type of restraint, or an installation error, meaning the technician found that the latch was not used appropriately or a seatbelt wasn't routed properly, and they indicated that. And then for the seats not recommended for use, those include things like a seat that's been in a crash, a seat where there's no history of it known, a seat where the labels have all been scraped off or washed off, and situations where a child came in with a forward-facing car seat, and for whatever reason, they left with a forward-facing car seat that was provided by the coalition. We also compared the restraint use on departure to the restraint use on arrival to see what impact these programs are having on the restraints that these kids have in their vehicles. The census doesn't have everything, but the variables that we felt were relevant to some of these early questions around disparity were indicators of poverty, including median household income, number of families living in poverty, female-headed households, rental properties, and households that didn't have any vehicles. We also looked at the Black group racial and ethnic composition in terms of non-white residents and those who were with a Hispanic ethnicity. And then recognizing that kids who are under 10 end up making up the target population for child restraint use, we also looked at that indicator. And this is just a little bit of a focused in look at the different elements for restraint type and misuse. I think the people who are going to be most interested in this piece probably already know these forms. And if anybody has further follow-up about that, I can show you that later. I know that there's a broad range of interest in statistics in this population of the audience. And so I'm going to give you guys hopefully enough to satisfy those who care, and not so much that I lose people who are just more interested in the results and the sort of summary of the information. But we did our mapping with ArcGIS 10.0 and our 10.1, and then we calculated our descriptive statistics and other statistics using Stata. We looked at participation rates and misuse rates calculated per household with children per census block group, and then used chi-square tests to compare the characteristics of the census block group among areas with high participation and low participation rates. And we used a 90th percentile as the threshold for defining high participation. For the misuse rates, we looked at that as a continuous variable and used the linear regression and compared the census block group characteristics to that outcome. And before I get to results, I just wanted to take a second and see if anybody has any questions that they want to touch on here. Good. For our Huron Valley sample, we had 1,300 seats checked, and 56% of those had a child present. About a third of those were expected parents, and then the remainder were people there with a car seat but no kid. Huron Valley distributed through the forms that were submitted to Safe Kids 526 seats, and the distribution of the restraints that were in use on arrival, the bulk of them are rear-facing car seats in the blue part of the pie, followed by a forward-facing car seat, booster seats, and then we've got this little sliver of kids who are using a seatbelt when they show up at a car seat inspection. In Greater Grand Rapids, we've got about double the volume of forms that were submitted through the Safe Kids program, and a little bit higher number of kids who were present at those, and a smaller proportion of expectant parents using these services. They distributed about 3 times as many seats as Safe Kids Huron Valley, and about half of their kids left with a new seat from the inspection program. Got a similar distribution in terms of the restraints in use on arrival, with a lot of rear-facing and forward-facing car seats. For both coalitions, about 2/3 of the inspections occurred at an inspection station, and 1/3 happened at what is called on the form an event. So that could be a health fair, it could be a big Safe Kid Week event that's happening in a parking lot of the Toys R Us in your community. But most of these families are seeking these services in fixed stations. For Huron Valley, those 1,300 kids came from 814 households, and we were able to geocode 98% of those. So I've got high expectations for Mike's ability to help us get to that point for our full state look at this that we're currently doing. These households were located in 401 census block groups, and 70% of those were within 10-mile radii around the inspection stations. The median number of checks per census group was 2, and so we're not getting a lot of car seats checked per census block group at this point. The red dots here show the locations of the child safety seat inspection programs affiliated at the time with Safe Kids Huron Valley. The little H is where Mott lives, and then the radii around that we're drawn to just give you a sense of the area that we're including. And we felt that people who were traveling 10 miles to a car seat inspection station was a reasonable expectation. There are, as you'll see on the next slide, are people traveling much farther than that, but we wanted to try to focus in on that group that was nearby to the resources at this point. Here we are showing the participation rates per 10 households with children per census block group. And you can see the raw numbers are low, but the gradation I think is interesting. The white census block groups had no participants, and the kind of dark amber color have the highest rates of participation. And you've got blocks of census block groups where we've got really high participation, and then some areas where we've got lower levels of participation. And as we're moving forward with additional research with looking at this from a full state perspective, I think trying to understand what might be driving some of these patterns. Is it word of mouth, and you get a first inspection done in an area and then a whole neighborhood goes, and then it expands out to another area? Or is it there was a big push in a certain community for a specific event and flyers were distributed all over the place and that got people interested? And I think that's an important step in trying to understand how we might be able to even this out in ways that are appropriate and still focus in on the areas that we have the highest risk groups for child passenger seat non-use and misuse. When we look at Greater Grand Rapids, we've got over 2,000 households. Again, 98% of those could be geocoded, and they're distributed over a little bit broader area in 503 census block groups. And their inspection stations are a little more spread out than the ones for Safe Kids Huron Valley. So we get 84% of the census block groups located within those 10-mile radii. We got a higher median number of checks per census block group, which I don't think is surprising to anybody given they had twice as many car seats checked. And for Grand Rapids, we have their inspection seat locations, and primarily those are centered in Kent County. Some of it spills out into near Ottawa County, and we've got the 10, 15, and 20-mile radii shown there. And we've got a lot more coverage in terms of area for census block groups that have at least one participant. And again, we've got specific areas where we've got higher levels of participation going on. And I think really talking with the folks who are leading these programs to try to understand if there are specific interventions that are happening in certain block groups that could explain these patterns is an important next step. All right, I'm going to try to show this in a way that I think is understandable, and if I'm losing people, let me know. What we did was looked at the indicators of poverty in terms of low, the bottom tertile, moderate, the middle tertile, and high, the highest tertile. And then graphed out the participation rates for census block groups that were categorized in that way. So participation rate is along the y-axis. The different indicators of poverty are along the x-axis. Low is the lightest blue, high is the darkest blue. And you can see here for groups that have the highest poverty level on median household income, so the poorest people have the highest use. And that pattern is fairly consistent across these variables, with families below poverty being both the low and high groups having the highest use, and with the households having no vehicles in Safe Kids Huron Valley having the highest use. And I wonder on that if you've got one person who has a vehicle and they're the ones going out to an inspection station, or if you have families who say, I know I'm going to be in a cab, and then I'm going to be in my friend's car, and then I'm going to be in here, so I really need to understand how to get this seat installed properly. I think the pattern's a little clearer and more consistent across the race, ethnicity, and child population variables that we looked at. And so we've got more non-white residents in that area and higher use of the inspection programs, which was a kind of warmed my heart counter to my hypothesis. And it does look like these programs are reaching some of the higher risk census block groups. With Safe Kids Greater Grand Rapids, I think with the volume of visits, we're able to see a little bit more clear trend here, and those high indicator of poverty populations have the highest participation rates across the board. And similarly, we see higher participation among the minority and child population variables that we had to look at there. So now this is a little bit more statistical look at things. So it confirms what was just shown in terms of participation rates. And I wanted to show the graphs because I think that's a little bit easier than just looking at tables that are full of numbers. But here we're doing chi-square analyses, looking at the high and low participation rate census block groups for the two different areas by the indicators of poverty. And you can see that the lowest median household income has the group that has the highest participation rate. And similarly, more families below poverty level, higher participation rates. And we've got a similar pattern both Huron Valley and Greater Grand Rapids. With the other indicators of poverty, we didn't have statistically significant differences for the female-headed households in the Huron Valley group, but the other variables were. And you can see we're up to 20% of the highest poverty census block groups having high participation. And then similarly with the racial ethnicity variables and the child population, all of those are significant for Greater Grand Rapids, and all but the children under 10 years of age were significant in the Huron Valley group. So I'm going to shift gears, talk a little bit about child safety seat misuse, and the results that we have there. Questions before I go on? Yeah.
So you mentioned earlier that you had hypothesized that maybe there was a time-dependent effect where people were going to car seat checks, and then you'd see an increase in their particular census block. Did you in fact see that when you looked at the different years of data?
So with this kind of year and a half worth of data, we didn't look at that, but for the next phase of this work that we're doing for the state right now, we hope to be able to do that. And we have 5 years of data that we're including, and it's got the whole state, which I think is an important aspect, because you might have somebody who lives in Lansing and drove to Ann Arbor, but there's something closer to them. And so trying to understand that full picture before making too many conclusions based on this information was where we wanted to be at this point. But I do really want to do that analysis. Yeah.
So in Huron Valley, we get the seats we distribute come from OHSP, and because of that, we're not allowed to accept any donations, even if people are grateful for our service. Is that also the case for Grand Rapids, do you know?
I am under the impression from talking with Allison Ketchkalo that that's a policy for OHSP distributed seats. But I don't know if people have other seats that they get donated through other resources, and we've got other people in the audience who know the answer, maybe.
I'm the tech. I just moved over here from Grand Rapids.
Oh,
so
yay!
I can speak to both. So the seats in Grand Rapids came from a different source, and they have grants that provide them at a discount because they found if like certain populations of people invested and paid a minimal amount, then they had more ownership of that seat. So for certain groups and people that came with referrals, they give away free seats, but then other seats came at a discount. So maybe instead of like $55, it was $25, and then they'd accept donations on top of that. But that didn't happen very often.
Thank you.
I forgot who I was speaking with, but they were saying that some coalitions, because they can't accept any donations if they accept OHSP seats, they prefer to get
decline the
from another
OHSP
source.
seat. Okay. Okay. There's another question.
Yeah. And I walked in a little late,
You're
but
okay.
I think I got the answer to one question was they can get a free seat or reduced cost seat. And then, as far as kind of marketing and advertising, did you ask people at all where they had heard about it or how they heard about it? And then, because I guess I'm curious if it's marketed more towards lower income populations anyway, and that's why you're some of this.
Absolutely. So I think that's an important step for prospective data collection. All of these analyses were based on data that were already in hand from program participants, so we don't have access to that answer, but I do think that that's an important question that we're trying to tap into. Yeah.
So, I was trying to process those numbers and.
Do you want me to put them up again or no?
Yeah, that's fine.
Yeah.
The question is, can you estimate what percentage of children who are sitting in harness restraints have been to one of these? Are you able to look at that at all?
I think we might be able to try to get closer to that with a full state look. And one of the problems is the data that we have access to for this project isn't population-based. And so I'm not entirely clear what our true denominator is. And we only have those who go through Safe Kids. And so there are inspections that are happening at other locations that we're not able to capture here. I think with the relationship we have with the state now, we now have a giant file cabinet full of forms from non-Safe Kids. And so we're gonna get closer, but I don't know with the more concierge kind of programs that are out there through some baby stores if we'll be able to get exactly to that number. I think we'll be able to get closer moving forward. All right, misuse. Looking at misuse overall, similar to that sad little toddler with the 3 out of 4 seats installed incorrectly, we had misuse identified in 86% of the seats at Safe Kids Huron Valley and almost 90% of those through Greater Grand Rapids. There was misuse in 95% and 97% of the census block groups that had a seat inspected. So misuse is out there. And when we looked at misuse as the outcome and looked at each of the census block group variables that we had at our disposal, we found that there were only 2 that were significantly associated with misuse. And for the Huron Valley sample, the census block groups who had the highest percent households with no vehicle had lower misuse. And it might be that they're coming without a seat installed, and so they don't have an opportunity for misuse. But we have a significant difference there. And then in Greater Grand Rapids, the census block groups that had a moderate level of percent Hispanic population had lower misuse than those with the lowest percent Hispanic population. Otherwise, with this rare event of correct use, we didn't see any differences across census block groups. Yeah.
Yeah, so this is either or, it's correct or it's not correct. Is there some means by which you could kind of rank order the level of not correctness but threat that the incorrectness represented?
So that's one of my implications, and I'm not going to jump ahead the slides to get to that, but I think it's a really important point, and it's one that we've got, I think, a handful of issues with these data. It's misuse as judged by a technician, and I think there's probably going to be a level of variation in terms of how tight does somebody say a seat has to be before they call it misused. And then there are a wide range of problems with these seats that I lumped up together into a single misuse, but we can look at it at an individual variable level. And I think with the right people contributing to the thought process around which misuses are most important in terms of crash risk, we could do those analyses moving forward.
Thanks.
But not installed at all is much more dangerous than you didn't have the harness buckle right here and it was right there. The other thing that I wanted to share with you guys is a comparison of the seats in use on arrival with the seats in use on departure. And the rows are the way that you should be looking across this information. So for Huron Valley, of the 630 kids that arrived in a rear-facing car seat, 95% of them left in a rear-facing car seat. Of the kids who arrived in a forward-facing car seat, 84% of them left in a rear-facing or in a forward-facing car seat, and 9% of them got moved into what I'd consider a more protective restraint. And as you go on down the diagonal, you can see that we have a decrease in the percentage of kids who are leaving in the same seat that they arrived in. And in the green boxes, I've highlighted kids who are leaving in, again, what I'd consider to be a more protective restraint. For some of the rear-facing kids going to a forward-facing restraint, it might be that they had outgrown their rear-facing restraint and forward-facing is a more protective. So I do acknowledge that as a possibility. And we assume that a tech is going to have somebody leaving safer than they arrived. But there is movement for these kids. And that pattern is consistent for Greater Grand Rapids as well. I think the main limitations in terms of looking at this from a participation rate question are getting at that issue of it's not a population-based study that we had talked about before. And I also acknowledge that the participants who come to these programs may not have the same characteristics of the people who live around them in a census block group. So we don't have an exact picture of the participants for child safety seat inspection programs at this point, but I think we're a step closer. And I also acknowledge that families can rely on other sources for child safety seat checks, but if we're only getting 2 per census block group or 4 per census block group, I think there's a significant number of kids out there who aren't receiving these services, even if they've got a lot of opportunities to go to a high-end baby store that doesn't submit forms to Safe Kids. And then the limitations around the misuse we kind of touched on in terms of the definitions and the not all injury risk is created equally. But from a conclusions and implications standpoint, I feel like these programs appear to be serving participants who reside in areas with higher degrees of poverty, non-white and Hispanic populations. So I'm encouraged by that finding. Our findings show that the services aren't not evenly utilized, and that might be okay if we're reaching the populations who are at greater need. We might not want to expend a lot of resources for populations that are able to get the seats installed correctly on their own. And as we look at this at a state level, I think we'll have a little bit better sense of that distribution of services and utilizers across the just underlying general demographic characteristics of people living in the state of Michigan. I don't know if anybody online or anybody here has poll with Safe Kids in terms of the design of their forms, but adding sociodemographic information to those forms would be an opportunity to gather a little bit more information about who's using these services. And I think it's probably a fine line to walk between then feeling like you're being profiled or identified, but it's a more direct way to understand who's using these services than trying to go with their address to get to their census block group. And then from the misuse standpoint, the Misuses I would have expected would be a bigger problem in areas where we have low education or other issues, and we didn't see variation in terms of the sociodemographic characteristics we had available in these data. And we didn't look at things in terms of that risk of misuse, but I think those are important steps to look forward as we're looking at data across Michigan. And I also think from a kids leaving in a more protective restraint standpoint, it'd be interesting to know how long that effect lasts. Is that an effect that lasts until they get to the garage? Or is that something that they sustain behavior change moving forward? So like I've been mentioning, we are currently embarking in a statewide assessment of child passenger safety needs and resource allocation. And it's a project that's funded through Michigan Office of Highway Safety Planning, and Ray and Kathy and Amy and Helmut and Mike are all helping out with that work right now. And we've got 5 years of data. We've got partners in the School of Natural Resources. We're going to get, I think, an opportunity to do much more sophisticated GIS analyses than what we were able to accomplish in this pilot study, and really try to get a better understanding of how this looks on a broader population level. And I've got lots of people to thank, folks who were with Safe Kids Huron Valley at the time that the study was conducted, Jennifer Hoekstra from Greater Grand Rapids, my K mentors, individuals at CHEER, folks at the Injury Center, and then Romeo Benoit at Safe Kids USA, who was able to provide us access to the data. And if you guys need to get a hold of me afterwards, you're welcome to reach out to me by email or by my desk phone, and I'm open for questions.
I'm curious what kind of
So with the analyses that are done for this project, I think since we now are with data from the whole state, we're probably not going to continue to conduct new analyses on this. But looking from a statewide perspective, we now have more data from the census that we're able to look at, and looking at education level and some of those other characteristics that are collected through the census to try to understand that. We're proposing to do analyses looking at distance traveled from home residence to the location where the restraint was checked, and try to see if people are going to the closest, or if they're going to inspection station that seems really hot and popular. I also am interested in looking at those trends over time to see if there is sort of a index person and then a spread of the services in an area, or if it's like a whole census block group shows up for one event and then that was it. And then with the School of Natural Resources folks, I think like getting more sophisticated maps and having those layers to look at, from where are kids in the state living, where are crashes with kids who are unrestrained occurring, where are parents who are unrestrained drivers noted to be at a county level, where do we have technicians in the state, where are the seats being distributed from OHSP, and how do those things line up?
So I'm curious if this whole intervention has been evaluated from a public health efficacy standpoint. I was thinking when you had that plot up there of what they arrived in and what they left in, you could kind of do a number needed to treat analysis on that, in the sense that we have some evidence from the field of what the relative, as you said, they're on average leaving in a safer scenario than they came in. Maybe there's a way to estimate just how many of those you have to do to get a fatality.
Yeah.
Are you aware of anybody who's done that?
I have seen nothing in the published literature that evaluates this program at all. So it seems ripe for collaboration and looking at those kinds of questions. Yeah, that's a neat idea. Yeah, Rebecca.
Yeah, it's super interesting, Michelle. I'm just, obviously you're working with the data you had, and really some really interesting things that I'm sure you thought some about, but what are the opportunities or your thoughts as to where you see this perspective?
I think from a prospective standpoint, you could start with just staffing researchers at inspection programs and getting a sense of who's coming, how did they find out about it. And then I think with a little bit more funding, following those families out 1 month, 6 months, a year from that encounter. Are they going back to those programs when their kids make a transition? Are they continuing to use those restraints, or do they end up collecting dust or in a resale shop? And really trying to understand what that impact is on a use level, I think would be a nice way to evaluate this prospectively. I don't know who would fund it, but I think getting some prospective information about this would be an important.
Yeah, and when you, in the section for the populations that are reaching, there's some discussion of families as well as, is there a part of this, what are the language differences at the site?
So with the state assessment that we're doing from the census variables, we're able to look at Spanish-speaking households and their distribution. And then from a survey of technicians, we have 3% speak Spanish, and that's the most common other language than English. And I was surprised at the small number of technicians who had a different language that they felt comfortable doing a car seat inspection in. I know that right now or tomorrow there's a car seat class that's happening to try to increase the folks who have a Spanish-speaking background who are trained to be technicians. And I don't know if you want to talk about that at all.
The Pediatric Trauma Injury Prevention Program just received a big grant from Toyota with the stipulations that we focus on the African American and Hispanic populations and really target technicians that are bilingual so that we have someone like within those populations that can also speak to those populations. So our 4-day class started today and will be, I think almost half of them are Spanish speaking. So we're hoping to utilize those people within their communities to reach the broader group also. So there are efforts. Unfortunately, it's not a Safe Kids one. It's a U of M one. But we also work very close hand in hand together. Fine gray line.
Yeah. Do you have technicians on your staff that put together this data, or are you a technician?
So I took the class and don't have time to be a certified technician. The data were put together from the forms. Amy's on my staff. Kathy is working now with us looking at the data moving forward, and Miriam Maneri is also on the team. So as we're looking at the data from the state, we've got broad representation, I think, from a technician viewpoint.
Just a one more question.
Yeah.
So we now have more of a state view, and I just wonder, so this program is somewhat similar in other states, and is there any ability to kind of take a big picture look?
I'd love to.
Right. So
I think if we can prove this concept using the Safe Kids data and have a better understanding of exactly how many human hours it takes to get the addresses all cleaned up, then we could propose
then you could get a much better sense of the cultural issues.
Absolutely. Yeah. Yep. Yeah. It's good to have verification that the thinking ahead is aligning with other people in the audience. Yeah, Mike.
Yeah, so kind of building off that, if this was like a perfect world, what would be your ultimate end goal? What would be the scenario?
So I think perfect, perfect results from my standpoint as an end receiver of kids in crashes would be that everybody who's involved in a crash who needs to come to the emergency department was restrained appropriately for their size. And I think there are many ways to address that issue, and with the complexities of car seats, until we can get manufacturing simplicities in car seat design. It's going to include the work of technicians and other people to help families navigate that. And so I think getting this program to reach the people who need those services most and reduce downstream effects in terms of injuries and fatalities would be my dream world. Yeah.
Unfortunately, one of our other roadblocks happens to be like the like pediatricians. So not all of them totally embrace like car seat safety, and a lot of them say that like families and mothers and caregivers can flip their babies around too early. So when you look at like the education level of a technician versus a physician, like families tend to listen to their physicians more, even though we have the backing of like the APA and other different groups. We're combating that also. So there are a lot of other forces just like outside of like lack of education. So it's a never-ending.
Didn't include that anecdote in this presentation, but when my youngest was 1, we went to the nurse practitioner visit for his well-child exam, and she's like, I guess they're now saying that you're supposed to keep going rear-facing. I was like, if that's as enthusiastic as you can get about this issue with me, we're in a bad spot. So I think that is the buy-in and the generational issues in terms of when I was a kid, I was in the backseat of a car or, backseat of a station wagon riding all the way to Texas, and I lived. And so you've got a lot of challenges in terms of the messages that families are receiving. Yeah.
Having worked on this project a bit, I think that this is a field that really hasn't taken to technology. This is a field where there's 36,000 technicians across the U.S. and they are meeting with parents who are filling out paper forms with a pen or pencil, which makes going through this data a bit of a nightmare, which is why we've brought some folks on board to help sift out these addresses. So there's so much room for improvement. Just the simple part of maybe making an electronic form so that those that are coordinating these programs, I mean, to have someone that maybe isn't trained in how to evaluate their program and make sure that they're hitting the right populations. The other thing we've discovered is not always are those that are coordinating these programs, do they have the training to know if they're reaching the right population. So there's so much room for improvement to enhance these services.
Your first intervention for donation for donor funds is to get iPads.
So I think we're at 1 o'clock, so I want to let people get onto their days because I know everybody's busy. If people have additional questions, they want to talk to me, I've got time to stay around a little bit. Thanks for coming.
If you haven't filled out your evaluation, please do so before you leave. And thank you to those who joined us online. We had 10 people who joined us on the webcast, so thank you all for coming.